Hello, everyone. Good morning, good afternoon. My name is Pablo Garcia, and I work as a pathology engagement liaison at Diaceutics. Welcome to this event organized by Diaceutics with the title Challenging Cases in Gastrointestinal Cancer, Pancreatic Cancer, and Cholangiocarcinoma. In today's event, three top-level experts in the area of gastrointestinal cancer pathology and molecular biology will discuss updates and challenges in the diagnosis, biomarker testing, and management of pancreatic cancer and cholangiocarcinoma, also using real-life difficult cases as examples. This is today's agenda. Dr. David Schaeffer will start discussing molecular and morphological assessment and classification of pancreatic cancer. Afterwards, Dr. Iglesias and Dr. Beatriz Bellosillo will discuss management and testing of cholangiocarcinoma using a clinical case as an example. At the end of the session, we will have time for questions, so I encourage anyone in the audience to write any questions they may have in the dedicated Q&A space so they can be addressed by the experts. This session will be recorded and available to watch on demand at Labroots website for everyone registered. Just a few words about Diaceutics. We are an end-to-end service provider and data analytics company. We have been working in precision medicine for many years with the aim of supporting biomarker testing so that every patient can get the right treatment at the right time. We believe that labs are key players that need to be involved earlier in the precision medicine decision-making process. With our better testing, better treatment mission in mind, we have built DXRX, a digital community aimed at enhancing data-driven precision medicine from which all stakeholders can benefit. Now let me introduce today's speakers. They are all very relevant experts in the area of tumor pathology and molecular biology with a vast experience in biomarker testing. We are honored to have today with us Dr. David Schaeffer, Dr. Iglesias, and Dr. Beatriz Bellosillo. Dr. David Schaeffer is an associate professor in the Department of Pathology and Laboratory Medicine at University of British Columbia and the head of the Department of Pathology and Laboratory Medicine at Vancouver General Hospital, where he practices as a gastrointestinal pathologist. Dr. Schaeffer obtained his medical degree from the Johannes Gutenberg University of Mainz, Germany. After a residency program in anatomical pathology in Vancouver, he completed his gastrointestinal pathology fellowship at Mount Sinai Hospital in Toronto. Dr. Schaeffer is the co-director of Pancreas Center BC and heads the gastrointestinal biobank at Vancouver General Hospital. He has an active research program focusing predominantly on translational research in colonic and pancreatic cancer. Dr. María Iglesias is a pathologist at Hospital del Mar, Barcelona, Spain, specializing in gastrointestinal pathology. She obtained a PhD in medicine and surgery from the Autonomous University of Barcelona. She is the head of the pathology department at the Hospital del Mar since 2024. Dr. Iglesias is associate professor in pathology at the School of Medicine in Pompeu Fabra University, where she is also a subject coordinator, assistant to the dean's office, and coordinator of the new curriculum. She is scientific director of the Hospital del Mar Biobank, current coordinator of the Gastrointestinal Pathology Working Group of the Spanish Society of Pathological Anatomy, SEAP, and also former treasurer of SEAP and collaborator in the quality program. Dr. Iglesias participates in multiple projects related to innovation at Hospital del Mar, mainly in digital pathology, tools for multidisciplinary tumor committees, biomarkers, and laboratory applications, among others. Dr. Beatriz Bellosillo is the head of the molecular biology laboratory in the pathology department at Hospital del Mar. She's also professor at Pompeu Fabra University. She's a member of different national and international scientific societies. Dr. Bellosillo has a wide experience in molecular biology applied to clinical diagnostics, as well as in translational research, having worked extensively in the area of liquid biopsy in recent years. She is also working in the Hospital del Mar Research Institute, IMIM, where she has conducted many research projects in the area of hematology and oncology, in which she has been the principal investigator. She has published more than 200 peer-reviewed publications with an H factor of 48 and developed 2 molecular biomarker-related patents that are currently in the commercial operating phase. So without further ado, let's start with today's scientific content. Dr. Schaeffer, the floor is yours.
Thank you very much, Pablo, for that very kind introduction. And I wish my Spanish would be good enough to give this talk in Spanish, but it's not. So I'm calling you this morning from Vancouver. We just survived the bomb cyclone of a wind. If you do not know what that is, I didn't know either until last night, but let me tell you, it's not something you really want to experience. So I'm very glad I made it to the hospital this morning. So I wanted to talk about pancreatic cancer, and I gave it a bit of a cheeky subtitle in the sense of, does morphology still matter? I do have a couple of disclosures to share with you, but importantly, none of the material presented is related to those financial relationships. So whenever we talk about the pancreas, it's always good to take a moment and step back and think about its anatomical location, retroperitoneally located, so closely affiliated with so many of the structures in the retroperitoneum. And as you know, we're talking about cholangiocarcinoma, and one of the biggest debates that I'm always having is what is pancreatic ductal adenocarcinoma if it's arising from the intrapancreatic portion of the bile duct? Is that a cholangiocarcinoma or is that a pancreatic ductal adenocarcinoma? And maybe we can have that debate later on if time permits. I'm also on a worldwide mission of ensuring the proper pronunciation of the duodenum. It's not the duodenum, it's the duodenum, meaning 12. So I thought I also spread the news here so we can get that nomenclature properly within everybody's mind. So when we talk about pancreatic cancer, and here's a gross image of it, it is always so striking, right, as to how small the organ actually is. You're looking at a diameter here of 2 centimeters, and the moment it passes the 2 centimeters, it often it's already past the confines of the organ and has gone into the retroperitoneum, rendering the patient often ineligible for curative intent surgery. And on a morphology perspective, on histology, right, we are also familiar with the incredibly prominent fibrotic tissue surrounding the epithelial cells. And many of our genomic studies are often hindered by the lack of getting enough cellularity within the tumor. And we haven't even touched the surface yet of the intratumoral heterogeneity in pancreatic cancer. And we often believe that a single biopsy taken by EUS with a 16 French needle is the truth of the entire tumor. Now, it also comes to no surprise to you that there are many challenges associated with pancreatic cancer. So here in Canada, our data are not very different than anywhere else in the world. We know that about 1 in 61 Canadians will develop pancreatic cancer in their lifetime, and the new cases are increasing. So we're currently looking over 6,000 pancreatic cancer deaths per year in Canada, and that number is approaching easily 8,000 by 2030. And if you think about it, right, there are many risk factors associated with it. Especially in the lifestyle area. Diabetes is both a risk factor as well as potentially a symptom for pancreatic cancer. We know that tobacco use and obesity all come into play for the incidence of pancreatic cancer. And we also have been spending a lot of time to determining if there's a hereditary predisposition for pancreatic ductal adenocarcinoma. And we're roughly knowing that there are some predisposition syndromes putting us in the 5 to 10% of all pancreatic cancer patients. And so in my institution, we have an upfront hereditary cancer screening independent of any kind of perceived hereditary predisposition by a patient discussion. And so arguably in most solid tumors, the challenges of pancreatic cancer is the fact that it is so often diagnosed at late stage. I'm showing you here Canadian cancer statistics and the differentiation of the stage at the time of diagnosis. And so the vast majority, 67% here, are stage 3 or 4. And if you just take stage 4, up to 80% of patients actually present in the metastatic setting. The other big challenge is that really there's limited therapies, right? The late detection and high recurrence is compounded by the fact that we have few therapeutic options. We have an incredible high chemo resistance in this tumor, and actionable targets are low. Arguably, the biggest ones are BRCA1 and 2 and its colleague PALB2. We're having a couple of gene fusions such as NRGN1 and NTRK that are coming into play, but overall, the picture is pretty grim when you think about actionability in pancreatic cancer. Now, when you look at all of the chemotherapeutic drugs that are being available, we are looking at median overall survival in first-line trials for metastatic pancreatic ductal cancer in months, not years. And I still remember when FOLFIRINOX entered the scene, the differences from gemcitabine and at this time as monotherapy to FOLFIRINOX seemed like we had conquered Mount Everest. And to this day, FOLFIRINOX and gemcitabine and nab-paclitaxel are the main stem of the therapy for those that have pancreatic ductal adenocarcinoma, especially in the metastatic setting. But I and many others believe that there's an unrealized potential for therapeutics in pancreatic cancer. And I like this. This is from a paper that Eileen O'Reilly published a couple of years ago, and that's really dicing the slice of therapeutic opportunities in pancreatic cancer. And obviously, you want to draw your attention to all of the different subtypes of KRAS mutations, which now, for the first time, lend themselves to actually be targeted in some solid tumors. We're just about to start that in pancreatic cancer. And so one of the big challenges is that the majority of patients in Canada, and I know that's not very different in other jurisdictions, don't have access to routine molecular profiling. Now, at my institutions, it has become a reflex panel-based approach to actually provide some kind of guidance to the oncologist up front, but there are many challenges associated with rolling this out in a larger stage, not the least of it being is that the cellularity of the tumor gives us problems, as well as the fact that we may not even be looking at the proper representation of the tumor given our current approach of tissue-only based subtyping. So when we talk about the pathology of pancreatic cancer, to this audience, this is clearly no news, right? The vast majority are pancreatic ductal adenocarcinomas, with a minority of being pancreatic neuroendocrine tumors. Interestingly enough, to this day, we still don't fully understand what the cell of origin is for pancreatic ductal adenocarcinoma. Is it acinar? Is it ductal? We don't really know, and research is ongoing in that field. As I mentioned, right, 80% of PDAC cases are late stage metastatic or locally advanced, so a minority is truly resectable. And our job in subtyping it, now that we have entered the stage of neoadjuvant chemotherapy in pancreatic cancer, is to bring those patients back into a resectable stage if they even present locally advanced or potentially metastatic. From a genomic perspective, as I said, it's predominantly KRAS driven, and we know that the KRAS wild type is an incredibly interesting cohort of patients, because that's where we see the vast majority of actionable targets such as NRGN1 fusions, which and we published on may respond to targeted treatment therapy. Now, P53 comes into play, but into a lower component in those patients. CDKN2A is obviously of interest, especially if we're talking about hereditary predisposition syndromes. And many of us are now using either FISH or CISH in settings of diagnostic uncertainty for CDKN2A to actually guide us in the right directions in the question if pancreatic cancer is in the differential diagnosis. SMAD4, about 40%. There is an IHC marker which may help you, but do know from a diagnostic perspective, it only comes up into about 40%. And then from a chromosomal structural variation, that is obviously also able to really subdefine pancreatic cancer. And we know that they usually come into play as stable, locally rearranged, scattered, and unstable. And those are the ones where we can often see a very high BRCA1/2 signature. And as I alluded to earlier, those patients are incredibly sensitive to platinum-based chemotherapy. And then arguably, from a transcriptomic perspective, this is where we've seen the biggest gains in understanding subtypes of pancreatic cancer in the last couple of years. And this is to really subtype pancreatic cancer in basal-like and classical. Classical having a better prognosis and basal-like having a poorer prognosis. And just like other organ system, it's this squamous quasi-mesenchymal subtype in the basal setting that can separate those pancreatic cancers. And so it's taken everything together, right? It's presumptuous to assume that you can really subtype pancreatic cancer alone on CNVs or SNVs. It's taken everything together to get a true molecular signature of that tumor, so that we can guide our colleagues in the oncology field as to choosing the right treatment for the right patient. But when we come back to pathology, the basal and classical stratification is arguably the most commonly used subtyping approach, and it gives a good indication to the oncologist as to how to stratify those patients. And as I alluded to, there are in the basal-like, there's some KRAS imbalances that might hint that this is a basal one. Keratins have been used. GATA6 is arguably the best to date IHC marker to allow the differentiation between basal and classical, and possibly the cell of origin can come into play. But we don't yet have a very good panel that we can utilize at the time of diagnosis at the microscope to really differentiate those. And as I alluded to, it probably is a combination of many things to get that molecular signature. But it is the understanding that not all PDACs are the same, right? There's traumatic intra and intertumoral molecular heterogeneity, and this will have an impact on the clinical outcome, the treatment stratification, and the novel therapy design. And we as pathologists are just at the beginning of understanding as to how this all will come into play. Now, I did start off by saying, does morphology still matter? Does morphology still come into play? And should we even still bother with looking at it? Well, I mean, I'm going to answer the question away. I do still think that tissue still matters. I mean, arguably, there are differences just on the morphology from a prognosis. And so I think it behooves us to, as pathologists, to still do the morphological assessment. And I think even if you go to things like specific subtype, like undifferentiated PDAC with osteoclast-like giant cells, which we published on a couple of years ago, even in cytology preparations, you can give those patients hope in the setting of a devastating disease, because as you are quite familiar with, this subtype, despite its name, actually has a very favorable prognosis, as shown in the Kaplan-Meier survival curve over here. So I do believe that just a morphological assessment of PDAC is quite helpful. And a couple of years ago, we did a deep dive where we went back into our molecular data and tried to identify any kind of morphological features that might correlate with the molecular signatures that I showed you earlier on. And my colleague, Dr. Nasel, published this paper now 3 years ago, and really demonstrated that tumor-infiltrating neutrophils and gland formation correlate quite nicely with some of the molecular signatures that we've been seeing in the genomic and transcriptomic analysis. And so we've actually taken this one step further now, and we have an AI algorithm that has been using those neutrophils and the gland formation to actually be able to subtype the pancreatic cancer at the time of morphological assessment into meaningful molecular signatures. So I do believe that tissue still matters. I do believe that pathology still has a role in the, if you so want, older approach of subtyping pancreatic cancer. But I do believe that the future is in understanding the genomic and particularly transcriptomic subtypes to allow our patients to have better outcomes. So I think I'll stop at this one and hand it over to you, Iglesias.
Thank you, Professor Schaeffer. It has been a wonderful talk. And now, as Pablo mentioned at the beginning, first of all, I want to thank the opportunity to be here with you. And as Pablo mentioned, Dr. Bellosillo and me, we are going to present a clinical case. I mean, in the title is already the diagnosis, but we will talk about the different classification of cholangiocarcinoma, having focus on the molecular diagnosis. So let's start. Our case is a male, 57 years old, active smoker with chronic hepatitis B, treated with tenofovir with complete viral response. During the follow-up by the hepatology department, they detect a mass in the liver. This patient was presented in the multidisciplinary tumor board, and because it was resectable, they decide to go to the surgery, and the segment 8 of liver was resected and was on 2017. We will talk a lot about time in these presentations. This was the sample we received. Is a well-formed mass, 4 centimeters of diameter, is touching the Gleason capsule, but also is touching the parenchymal margin. We can see it macroscopy and was confirmed microscopically. The tumor was composed of those typical glands surrounded, or ducts surrounded by desmoplasia, infiltrating the liver parenchyma. And going a little bit deeper, this neoplasia, this cholangiocarcinoma, was composed of these small ducts surrounded by desmoplasia, and the atypical irregular ducts were composed of these cuboid atypical cells with nucleoli. So the main diagnosis, the global diagnosis, was small duct-type intrahepatic cholangiocarcinoma. At that moment, I would like to mention that the WHO classification of cholangiocarcinoma from 2021 classified them through the anatomic site in 3 big groups. And this subclassification is important because the different groups could have different etiopathogenesis, risk factors, incidence, and also prognosis. The main focus from the talk of today is going to be an intrahepatic cholangiocarcinoma. They could be between 10 or 20% of our cases. Those neoplasias arise from the bile ductules to the segmental duct, and of course are intrahepatic. The macroscopy of these tumors could be a mass forming, like our case, but also we can find this periductal infiltrating pattern or also intraductal growing. We've got another percentage of tumors that arise in the periilear area, periilear cholangiocarcinoma, and those are the most frequent ones, from 50 to 60%. Those arise in left, right, or common hepatic duct, and they have mainly an intraductal growing pattern. And finally, the distal cholangiocarcinoma, they are supposed to be around 30% of our cases, arise in the common bile duct, and they also have this intraductal growing pattern. Why is important this? Because these differences in the anatomic size will be related also with differences in the histologic pattern and also in the molecular alterations. Going to the histologic classification is recommended to try to specify how big is the duct that is composed the cholangiocarcinoma. In the conventional intrahepatic cholangiocarcinoma, we mostly have two types, small duct type and large duct type. The small duct type is thought to arise in these interlobular bile ducts coming from these cuboidal cholangiocytes. The large duct type is coming from these peribiliary glands or the surface epithelium, these more columnar type cholangiocytes. In the intrahepatic cholangiocarcinoma, we can have another pattern, the cholangiocarcinoma. The typical ducts are very small, and they are supposed to arise from this bile ductule or even from ductular reaction in an inflammatory setting. And finally, the extrahepatic, most of them used to have this big, large appearance, and they are used to come from this surface epithelium in the columnar cholangiocytes. The final diagnosis of our case was a bile duct adenocarcinoma, small duct subtype, intrahepatic, grade 2, moderate differentiated, 4 centimeters of diameter. We saw also lymphatic and small vessel vascular invasion, and also multiple foci of high-grade intraepithelial biliary neoplasia. And as I mentioned, the margin was positive. So oncologically, it was an stage 2, and the patient go for adjuvant capecitabine for 6 months. And luckily, January 2019, the patient has a recurrence on the site of the previous surgery with some satellite lesions. So the patient at that time was unresectable, and the oncology decided to start the first line of systemic treatment with cisplatin and gemcitabine. This was 2019. This was the regular treatment. I need to mention at that time now that in 2014, this first line treatment include durvalumab. It's an anti-PD-L1. During the follow-up after this first-line treatment, the best response was a partial radiological response. The patient had some toxicity and also asked for the treatment rest. So he stops this first-line treatment September 2019. Unlikely, again, this patient had a progression 2021, unresectable, and starts with the second-line treatment with FOLFOX. But also, Dr. Avisa is our oncology, ask us to try to find some biomarker. We perform mismatch repair protein and NTRK by immunohistochemistry, but we started to perform NGS panel with DNA and ERN, but we needed to pick the sample for the surgery specimen that was taken on 2017. The patient continued with to FOLFOX and was stable for a while. At that point of the case, of the clinical history of our patient, I would like to talk about these molecular alterations regarding or related to the different anatomic classifications. With this figure is very important. We can see the amount of possible molecular alterations that we can have in the intrahepatic cholangio, but also in the extrahepatic cholangio and gallbladder. Most of them are potentially target therapies, but the ones that are highlighted in red are already target therapies for these specific mutations. FGFR1, 2, you can have amplification, fusions, mutations, overexpression of HER2, IDH1 and 2 mutation, BRAF mutations. So knowing that is very important, and we will see in the next slide that comes into clinical guidelines. We need to test the molecular because we need to offer target therapy to our patients. And some of these molecular alterations are related also with poor prognosis. For example, mutations in KRAS, BRAF, or HER2 overexpression are related to worse prognosis. Focusing in the intrahepatic cholangiocarcinoma, nearly 40% of the cases will harbor druggable alterations. And for that, the guidelines recommend the testing, the molecular testing through NGS to these specific patients to try to pick a target molecular therapy. I mentioned that ID8, FGFR2, KRAS, I cannot see it properly, BRAF, HER2. So we need to find them to increase the survival of our patients. You are mute. Bea, you are mute.
Thank you, Mar. And thank you. I take the opportunity to also thank you, Pablo, for the opportunity to be here today. So continuing with our case, we performed this molecular analysis by next generation sequencing using DNA and RNA. On the left-hand side, you can see the results of the NGS DNA panel looking for mutations. It was 2021 when we performed this. And at that time, this was we were using a small panel in routine clinical practice. We found no mutations in the DNA panel. And when we looked for fusions in the RNA, the first result we obtained was a non-evaluable result. So RNA was not of quality enough. This is one important thing to have in mind when we are starting to do the search of gene fusions. Many of us are very used to look for fusions in lung cancer samples. Cholangiocarcinoma has arrived later. Not always our samples had been taken with all the care that should be put on this type of samples, because until now we didn't need to perform this molecular analysis using RNA. This had been the case for this patient in 2017. Remember that we did the obtention of this sample. At that time point, when we reviewed the case, we realized that the sample had been 24 hours since surgery until it arrived to our pathology department. So although it was in principle sample of enough size, the first results for RNA were non-informative. However, as the size was big enough, we had generated several capsules. So we performed a second extraction of RNA from another block of paraffin, and there, yes, we obtained an RNA of quality. We could perform the NGS panel, and the result was that we did not detect any fusion, including FGFR2 fusions. We had the opportunity to send the sample to an external vendor to perform a broader NGS panel looking for options for this patient. And when we get our result back from the Foundation Medicine result, we obtained a result with an FGFR2 fusion. So it was a fusion between FGFR2 and TAC2 protein. So what had happened here in this case? When we reviewed our, before that one, what happens here with the FGFR2 fusions? FGFR2 is a gene that can get fused to a big number of additional partners. Here in this slide, you can see many of the partners that have been described so far. The most frequent is big one, but there are many others. So this will be an important challenge when performing the NGS analysis. Also, of course, we have mentioned, and it's highlighted here, that sometimes we may have insufficient or poor quality samples. So this makes it very important to optimize the NGS strategy that we are doing when we are looking for targetable genes in cholangiocarcinoma patients. Very briefly, from a molecular review of how we are dealing with the look for fusions in NGS. We can use two approaches to perform NGS. We can perform a hybrid capture approach, or we can perform an amplicon approach. If we are doing the hybrid capture approach, what we will do is have a probe that will bind to the gene we are targeting, FGFR2 in this case. We will bring down those DNAs mostly that have FGFR2, and this will mean that we will be able to capture both those fusions with known partners, but also the fusions with unknown partners. So in principle, this will give us a higher capacity of capturing different fusions, which is the case for the FGFR2. If we are using an amplicon-based, that's case B, we normally will be designing a PCR with two primers to perform amplification of the fusion we are looking for. So we have to know which is the partner of the gene we are targeting to be sure that we are capturing. There's also an option that has been more recently developed using adapters. It's called the anchored multiplex PCR, that you bind an adapter so you may be able to capture both known and unknown partners. In our case, at that time point, we had performed an NGS with amplicon base without this anchored approach that was designed to capture these 10 fusions that are listed here. Among these 10 fusions, we don't have the FGFR2 TAC2 fusion that was the one that was burying our patient. So this was the reason why we get a negative result in our testing. More recently, we have incorporated a broader panel that captures all these FGFR fusions that you have listed here. Among these, yes, we have the FGFR TAC2 fusion, and in fact, when we reanalyze the sample with this new panel with the same RNA, 2 years later, we were able to detect the fusion, as you can see here at the right-hand side. So the important point I want to highlight here is that you have to have in mind that not all NGS are equal. So NGS is a strategy of doing parallel sequencing. However, when we are doing NGS, we may be doing small gene panels or broader gene panels. We may be doing only DNA or DNA and RNA, and sometimes for both DNA and RNA, we have also different strategies, and these evolve during time. So it's important that when we have a case where especially we have a negative result, we should try to go a little bit further and see if we can either plan, although we have already done NGS, to plan another type of NGS that could bring additional results that perhaps we are missing with the panel we're using. Very briefly, just to talk a little bit of FGFR2. FGFR2 belongs to the family of fibroblast growth factor receptors, where we have 4 full receptors, FGFR1, 2, 3, and 4, and a 5th receptor that lacks the intracellular domain. These receptors play an essential role in cell proliferation, migration, metabolism, homeostasis, tissue repair, and also in avoiding apoptosis. You can see on the right-hand side a scheme. The idea will be that once the ligand, there are many ligands, more than 20 ligands that can bind to the FGFR receptors. Once the ligand binds to the receptor, it's going to activate all the intracellular cascades. There are several cascades, MAP kinase, PI3 kinase cascade, also the JAK-STAT cascade, and would lead to the activation of cell proliferation. In solid tumors, we have there has been described alterations affecting FGFR in around 7% of all solid tumors. These alterations can be either amplifications of the gene, resulting in a higher amount of receptor, also mutations either in the extracellular, the transmembrane, or the tyrosine kinase domain of the receptor, and also rearrangements leading to gene fusions. In intrahepatic cholangiocarcinoma, FGFR2 FGFR2 fusions have been identified in 10 to 15% of cases. These cases are associated with a better prognosis and in general with a younger age. And the interesting point right now is that this is an actionable target because several inhibitors have been developed in the last years. First generation inhibitors were multi-kinase inhibitors that would be targeting several receptors. More recently, the receptors, the second generation, are more selective of specific receptors, including the FGFR2 receptors that we are going to be talking about.
So continuing talking about this selective reversible oral tyrosine kinase inhibitor, pemigatinib, I would like to present this clinical trial, the phase 2 FI-202 trial. In this clinical trial, were included cholangiocarcinomas, 80% of the patient in first or second line of treatment. Almost all of the cases were intrahepatic cholangiocarcinoma, and the patients were stratified depending on this FGFR alteration. In cohort A, the patients were harboring FGFR2 fusions or rearrangement. The cohort B were patients with cholangiocarcinoma harboring different FGFR2 alterations, and the cohort 3, the C1, was FGFR no alterations. All these cohorts were treated with oral pemigatinib, 13.5 milligrams per day. And the primary endpoint was objective response rate reviewed by an independent central hospital. And also they found, or they analyzed the secondary endpoints, including duration of response, disease control rate, progression-free survival, overall survival, among others. In these slides, I would like to show what happens regarding objective response rate and disease control rate only in cohort A. We can see that up to more than 80% of the cases has disease control rate, and also 37% has objective response rate. Is pretty much, and mostly comparing with the objective response rate of the cohort B and cohort C that was 0. And also the median duration of response was 8.1 months. It's amazing also the Kaplan-Meier of overall survival. We can see how separate are the lines of the different cohorts. The median of increasing survival, the median survival was 17.5 months in the cohort A. And it's important to mention at that point that the patients with cholangiocarcinoma till then did not have a survival longer than 12 months. And those results lead to the approval by the FDA in 2020 as pemigatinib treatment of cholangiocarcinomas harboring FGFR2 fusion or rearrangement in more than first-line treatment. This approval arrived 2021 to Europe. It was approved by European Medicines Agency, but in Spain, the reimbursement arrived 2024. I mentioned that because our patients needed the treatment before 2024. At that time, this is the first molecular target therapy approved in biliary tract carcinomas, pemigatinib related to FGFR2 fusions. Let's continue with our clinical case. In January 2022, progress. So it was the time we already knew that the tumor has this FGFR2 fusion. So the best option was giving pemigatinib. The problem is that in Spain, we didn't have the reimbursement. So our oncologists used this expanded access program, and the patient could enter in the FIGHT clinical trial. Again, unluckily, the patient had toxicities and he needed to reduce the dose of pegamitimib. And in November 2022, it has progression of disease. At that time, academically, we test what happened in the liquid biopsy of this patient.
Yes, we had the opportunity for this patient to perform in the academic setting analysis of liquid biopsy samples sequentially. You can see the first liquid biopsy was from October 2021, so before starting the therapy. There you can see in this light blue the FGFR TAC2 fusion that was detected at the very beginning. During the therapy, we performed a second liquid biopsy. It was 18 May 2022. There we can see that the TAC fusion, FGFR2 TAC fusion is not detected. And afterward that, we had 2 additional liquid biopsies, September and December 2022, where you can see that the fusion is being detected again. At the same time, at these 2 time points, you can see on the lower part of the table that we started seeing several FGFR2 mutations with low allele frequencies of around 0.2% approximately. These FGFR2 mutations are most mutations associated with a resistance to the therapy. Resistance mechanisms have been described for FGFR. Some of them are primary mechanisms of resistance that may either affect the receptor directly or also the downstream signaling pathways. But for a secondary resistance, mutations mostly affecting the tyrosine kinase domain have been described, and you can see them listed here for the different receptors in response to the different targeted therapy. In the case of our patient, as I said, we detected several mutations at the same time. That has been already reported in different clinical trials, that these mechanisms of resistance frequently are polyclonal mechanisms of resistance.
And finally, no, that's it.
Sorry.
Let's see what happened with our patients. Unfortunately, the patient go wrongly. He started the fourth line of treatment included in a clinical trial with another tyrosine kinase inhibitor, futilibatinib, but it had also toxicities. He stopped this treatment. He entered in the 5th line of treatment with irinotecan, and finally the patient died in 2023. We want to mention at that point that the patient lives 6 years comparing with the overall survival of a metastatic cholangio that is more or less 12 months, and also with a quite good general conditions. I would like to finish my part before the global conclusions, making these clinical conclusions. This is the guidelines for metastatic cholangiocarcinoma or locally advanced in the right part of the slide. And the guidelines recommend us to test molecularly the neoplasias to see if we can find a target molecular driver alteration that can help to select the better treatment option for our patients.
And with this, we would like to conclude the following. Number 1, that it is essential to perform molecular studies in patients with unresectable or metastatic cholangiocarcinomas that may be candidates for targeted therapy. 2, that the FGFR2 fusions need to be identified, as there are approved inhibitors in second line now available for these patients. This may probably need to perform some pre-analytical optimization during the sample collection process. And also to have in mind that not all technologies are equal and that we have to be very conscious of which type of technologies we are using, especially NGS technologies, to see if they are optimal for the detection of these fusions, and if they are not, try to either change them or look for other options to be able to perform the best analysis possible. And finally, that the use of liquid biopsy is a complementary strategy to perform this analysis. If they cannot be done in tissue, or if we consider that tissue is very old, in the sense that perhaps the patient has already received several lines of treatment. And one important thing in precision medicine is that these liquid biopsy samples are going to be very useful for disease monitoring and for having a real-time picture of the molecular alterations present in the patient at every moment. And with this, we would like to end our presentation, and thank you very much for your attention.
Thank you very much, Dr. Iglesias, Dr. Bellosillo, for this wonderful presentation. Thank you very much also, Dr. Schaeffer, for your excellent dissertation about pancreatic cancer before. Now it's time for questions for the speakers. I really encourage anyone in the audience having a question to write it in the Q&A box. It's not every day that you get the opportunity to be together with experts such as Dr. Iglesias, Dr. Bellosillo, Dr. Schaeffer. So please use this opportunity and don't be shy.
Can I make a question?
Sure.
To Professor Schaeffer? I'm sorry. It's because I don't know if I understand right. Do you perform NGS testing to every metastatic pancreatic cancer to have this information?
Yes, we do. So we do, it's not just metastatic, it's also in the resectable one. So we do reflex testing NGS for all pancreatic cancers coming through the door.
DNA and RNA, both?
Yeah.
Dr. Bellosillo, we can start to
yes. We will try to incorporate that part too. Yes.
It gives you a lot of information. Yeah. It helps to understand. Daniel, please. Yeah.
So in the meantime, while we get any question from the audience, there's a question. Which is for Dr. Iglesias and Dr. Bellosillo, but of course, any of the speakers can contribute with their opinion, and has to do with specifically NGS, how we perform NGS, and when do we perform NGS. NGS is very important, has been shown for cholangiocarcinoma, also for pancreatic cancer, but for cholangiocarcinoma is included in many guidelines, so it's really important. But in the real world, not all the hospitals, not all the labs have the same resources or the same knowledge or experience when it comes to molecular profiling by NGS. And this is especially true with the detection of gene fusions, which can be more complex than what we are used with DNA hotspots or smaller panels. What's your opinion about using a centralized model for this type of testing, in which there are big reference centers, versus implementing these technologies in as many different hospitals or labs as possible? There are different models all across Europe and also in the Americas. So I would like to know your opinion on these strategies.
I think this question should be answered by Dr. Bellosillo, because she can explain what's going on in our region, in Catalonia, and I think is the way it needs to be, at least now. So, Bea, do you think you can explain a little bit what's going on with the reference sites, NGS centers?
Yeah, sure. Thank you very much for the question, Pablo. I think that's a very relevant question. I think the most important thing to have in mind is that FGFR2 fusions are not is not performing a KRAS mutation detection or an EGFR mutation detection. They are much more complex. So it's important for those centers where NGS is being done to be to know which type of NGS you're performing and to be sure that you're capable at least of detecting as many fusions as possible. No? That's important. In this being said, that means that to have reference sites is an opportunity to ensure that the best technology is applied to the sample from your patient. As Dr. Iglesias was saying, here in our region, now we have a centralized NGS opportunity for all the metastatic patients, including cholangiocarcinomas, as there is a drug that can be given to these cases. And so there are reference sites where smaller hospitals can send their samples to perform this type of analysis. I know that at least in our country, this is the aim of implementing such a strategy, but that's a little bit slow, and it's a work that has to be done. Also, in the meantime, I think it's important that because sometimes you have the opportunity to send to an NGS reference site, but to optimize all the sample collection is also an important point. Because for many cases, we're going to be needing RNA, and to have RNA is a labile molecule that gets degraded very quickly. So to have a good collection circuit and a good pre-analytical fixation and a preparation of the sample, that's going to be critical too.
Totally agree.
Thank you very much, Dr. Bellosillo. Dr. Schaeffer, do you want to add anything about this?
Yeah, I think it's the age-old question, right? Tiers of services for molecular assessment. I understand the need for centralized testing, just because technology advances and you need to have a critical mass to understand all of the aspects going into it. And I fully agree with the statement being made that not every NGS panel is the same. Having said all of that, I also believe that we cannot get into a scenario where everything just gets sent to a central organization. I do believe that smaller institutions need to be taken along, and we need to be able to provide the same type of information at those sites. And I think for the trickle-down effect, right, of knowledge generated at academic centers and then to be sent out to, for lack of a better word, non-academic hospitals is something that isn't fast enough. And I think all of us in academia have a duty, right, to ensure that this actually is done as fast as possible.
Thank you very much. I still encourage anyone from the audience, in case there's any question. In the meantime, let's go with another question for Dr. Iglesias. This is about HER2 in cholangiocarcinoma. HER2 is among the targetable biomarkers that you can test for in cholangiocarcinoma. How does it behave? Can it be tested by immunohistochemistry as in other tumors? And are there positivity thresholds for the overexpression clear, or is it a different scenario, for example, compared to gastric or other tumors?
This is a very good and tricky question, because in fact, HER2 in cholangiomas can be tested by immunohistochemistry, but there are not specific guidelines for cholangiocarcinomas to do the testing. So from now, we tested like gastric point cutoffs, for example, but they are not specific for cholangio. They are for colorectal, but also a little bit of mix, because there's a Iglesias, or you can also use the gastric or breast. And for cholangio, there's less published, and we are testing like in gastric through immunohistochemistry. In fact, I've got one case today amplified through gastric. We have one amplified today.
Okay, thank you very much. Thank you very much for your answers. So there's still knowledge to generate about that, about the behavior of HER2 in cholangiocarcinoma. Okay, maybe we have time for one further question. This one would be for Schaeffer. Again, if any of the other speakers want to contribute, just don't hesitate. Even though BRCA mutations appear in pancreatic cancer, the use of PARP inhibitors has proven to be less effective than in other tumors with BRCA alterations, such as breast or ovarian cancer. Is there any theory on why this approach has been less successful in pancreatic cancer? And also, would you recommend to test also for HRD, including genomic instability, if possible, in pancreatic cancer?
Yeah, I mean, HRD obviously is very important in the overall scheme of DNA repair, and has proven to play a role in pancreatic cancer. I think to answer the first part of the question, right, that PARP inhibitors have proven to be less effective, I would argue that where they have proven to be less effective was in a trial design that did not take subtyping into account. So I think statements like, oh, PARP inhibitors don't work in pancreatic cancer should be rephrased, and PARP inhibitors don't work in pancreatic cancer that don't have a molecular signature supports their response. And so I think a lot of what we're doing right now, right, is like looking backwards and not repurposing, but understanding why some of the trials didn't work. And I think there's so much valuable data in the negative trials, which don't usually lead themselves to being published in high impact journals, but to understanding as to why things didn't work and why we potentially have an opportunity to re-examine with proper understanding of subtypes of tumors, which one would respond to certain treatments.
Great, thank you very much for your reply, Dr. Schaeffer, once again highlighting the importance of doing proper molecular testing and why this is important to the patients. Okay, so I think we are right over the time. We may not have time for more today, as it's time to close this event. Dr. Schaeffer, Dr. Iglesias, and Dr. Bellosillo, thanks a lot for your wonderful presentations and for all the wonderful information that you have discussed here today. I remind the audience that this event will be available to watch on demand at Labroots website. And thanks everyone, and see you in the next Diabetes event. Thank you very much.
Thank you
Thank you very much.
Bye.
A pleasure.
Thank you.
Bye.
Bye.